Hey D&D fam. I'm Quick.
And I'm Lee, and you're listening to
Divas and Ducats. So what is a diva? I think divas get a bad rep. But to me, diva is all about the attitude.
As for ducats, it's your finances, your assets, Skrilla, guap, your coin. We're talking all things with the potential to affect your pockets.
And while we're attorneys by trade, we are divas by choice. Divas and Ducats is for edutainment purposes.
Y'all, we are not Series 511 or 703 professionals. This does not create a financial advisor or attorney-client relationship. The views expressed here are solely our opinions and the opinions of our guests.
It's just our opinions, y'all. Okay, divas, let's talk ducats.
Hey D&D fam, welcome back.
Welcome back, Lee, to the table. I've missed you.
So on our Diva docket today, we are talking about the bell tolls. So as usual, we have a coin adjacent conversation. A lot of women are prolonging for various reasons, becoming mothers, and that can have financial impacts, both positive and negative. And so we wanted to talk with another subject matter expert in her field, just talking about some of the pros and cons, both health-wise and financially, to having children at what is medically called, I guess, advanced maternal age. So we wanted to get into that, especially because this month is awareness around a lot of the, gynecological cancers. And so we wanted to bring awareness to that and just talk through some things, right?
Yeah, for sure.
All right. So who do we have?
So we have Dr. Cynthia Wesley. She actually is a previous guest of ours and one of our favorite resident doctors. She was on last year. If you did not catch that podcast, go back and search. We talked about maternal health and was really getting into a lot of the issues that you see with having a non-African American doctor, and just having a lot of your concerns not really taking them seriously. So that was a really, really great episode, and we have brought her back this time to talk about advanced maternal age.
So before we get into that, we got to announce our Black Wealth Summit.
Oh, yes.
Don't want to forget. So, we are hosting the Black Wealth Summit that is being held in Greenville, South Carolina, October 1st and 2nd. You can attend virtually or in person. Tickets are available if you go to our link in bio on our Instagram, Divas and Ducats, or our website, divasandducats.com. You can see that as well as the discount code for a limited time.
We are super excited to be host of that, of the virtual segment of that Black Wealth Summit. It's a great opportunity, and we hope to see some of our D&D family there. So like she said, go into our link in bio. You can click and purchase tickets and attend.
Yes. So back to the issue at hand.
Right. So we want to welcome Dr. Wesley. Say hello to the D&D family.
Hello, family. Thanks for having me tonight.
Yes, we are so excited to have you back. So tell the people that have not heard about you from our last episode, tell them a little about what you do.
Well, I'm Dr. Cynthia Wesley, better known as Dr. Cyn. I'm a board-certified OBGYN, national speaker, best-selling author, and vulvar skin specialist. So that's skin down there, okay? Right. I help to understand and maximize the skincare of the vulva. And you guys know I like to call it the private phase.
Yes.
And my objective is for every woman to know that the private phase is just as beautiful as the public phase.
Right.
I love it.
Yes, we love that. And so in your field, what do you do in your field?
Well, I'm an obstetrician gynecologist.
Okay.
Right. So I take care of women from every stage of womanhood. So not only am I performing your annual exams, as well as if you have problems with ovarian cysts, fibroids, things of that nature, but I also deliver babies. Right? So I take care of you during pregnancy, during delivery, and also during that very critical postpartum period. And with all of my traditional practice, my passion passion area is really dealing with the private phase.
Yes, we love
Very
that.
good.
So, in relation to the bell tolls, which is what we know the medical term is advanced maternal age, which that's what they always tell women, right? Like
you're running out of time.
You're running out of time. The bells ringing. So it's always this time clock with us, right? And so in the medical I guess world, what is considered advanced maternal age, or a geriatric pregnancy? Is that also?
That term is out there, geriatric pregnancy. I don't like it.
It's kind of rude.
It is quite disrespectful. However, advanced maternal age is 35. Okay. So 35 and older is considered, for most, advanced maternal age. On some research and in some countries, they may use 40 as advanced maternal age. And then extreme advanced maternal age would be those, for some places 45 and over, others 50 and over.
Oh, so it's levels.
There are levels.
There are levels to this.
Yeah.
Okay.
And so what is it about 35? Like what is it about 35? Because of course, as women tending at 35, we kind of feel like we're starting to just get our foot, right? We found ourselves. So what is it about our bodies that say, nah, sis? Right.
Well, I think that you brought up a very important feature, right? Is so much has changed over the years. Women have evolved.
Right.
So if you even go back to your grandmothers and your great grandmothers, they were having kids at ages that now we would be calling child protective services, right?
Right.
Yes.
Right. Young girls having children at that age, but that's what was normal for them. Now you have more and more women who want to prolong childbearing for their careers. They want to have more financial stability first. They are prolonging getting married until later in life. So there's a lot of factors as to the why.
Right.
You see more women that are above the age of 35. But there are real medical issues that may be of concern. Okay. Now, it's not extreme. Now, when you get to 50, things of that nature, that's a different story, and we can touch on that. But because more and more women are actually having children later in life.
Right.
But you just got to be aware of some of the risks that you may be prone to. For example, miscarriages.
Okay.
All right. So the older you are, the more likely you are to have a miscarriage. Also, chromosomal disorders. Okay. Like I know you guys heard of Down syndrome, things of that nature. As you get older, the risk does increase for that. But nowadays we have testing that we could do. We have cell-free DNA testing that we can do very, very early in the game, so you can sleep better at night during pregnancy, knowing that everything looks good. Of course, your ultrasounds done throughout your pregnancy, looking for anatomical abnormalities. Now, other than disorders that are related to your chromosomes, as you get older, you are at increased risk for some birth defects, mainly heart defects. Okay. Once again, you'll get ultrasounds just to make sure everything continues to look good. You're at increased risk for high blood pressure, even preeclampsia. You're at increased risk for diabetes. Now, some of that is simply related to the fact that your body odor. Right. Period. So you're more likely to see a woman not pregnant, more likely to see her with hypertension or even pre-diabetes at 40 than you are for that same group of women when they were 25.
Right. Absolutely.
Right. So there's natural changes to the body related to pregnancy you then have to deal with during pregnancy. Right. But even if you don't already have those conditions, there are increased risks once you're over the age of 35. Ectopic pregnancies. There's a higher rate of ectopic pregnancies. All right. Women who are above the age of 35 may see an increased risk for a C-section. Studies have shown that they're at increased risk for postpartum hemorrhage. Now, I think when you look at those studies, that doesn't necessarily mean, oh, you're 40, so you're going to bleed a lot. Right. When you think about it, the majority of women who are 40, they've already had a whole lot of babies, right? So some of that is just related to what we call a grand mal parity person, right? Where they've had lots of babies. So their uterus has been expanded and collapsed multiple times. And that's what increases their risk for heavy after delivery. So you can't throw the woman who's never had a baby, right? Then pregnant. You can't really throw her into that group.
Got you. And so you mentioned within those risks just things about, we're prolonging, right? So what are some of those measures that women can take in terms of if they're looking to, I guess, preserve fertility? Because unlike men who can pretty much procreate forever, women don't have that ability, right? And there's still that pressure of, although society is changing, biology is not. So what are some of the things that women can be doing to kind of preserve that if they're not quite at that point?
Right. Well, first, in general, holistically, you need to try to be as healthy as possible. Okay. That's very, very important. When you're battling obesity, hypertension, diabetes, it's just going to make the process of getting pregnant so much more difficult. And then your pregnancy even more high risk than the average woman 35 and older. Okay. But you can freeze your eggs. Right? So that is an option. I wish more women would consider it because, we're waiting later and later, and there's two different ways that it could be done. Okay. So we can just freeze the egg itself. Where it's just your egg, and we don't have a mate yet.
Right.
Okay. Maybe you got a mate, but you're
not too sure about them.
Right. And so you just want to freeze your egg. So that's an and then it's also an option to freeze embryos. Okay. Where maybe you're married and you guys just know you're not quite ready yet. You have some financial goals that you would like to achieve first.
Right.
And so you can freeze embryos as well.
Okay. And so embryos, just for they're fertilized eggs.
There it is.
Okay.
Right. Okay. So we took the egg, we took the sperm, we put them together. When it gets to a certain stage, we remove it. We freeze it, and then when you're ready, we thaw it out, and we put it back in.
Got you. Okay.
Right.
And so, is there with doing that, because you said you could do it two ways essentially?
That's right.
Is there an optimal age to do one versus the other, or does it really matter?
Well, it doesn't really matter age-wise, one or the other in general. Okay. We do know that with using an embryo, we have way more success.
Got you.
Than just using the egg or the oocyte. Okay. So that is known. Studies have shown that. But as far as women who maybe don't have a partner, but they really want to preserve their fertility, the optimal timing for that is between age 30 and 37.
Okay. Gotcha.
Because our eggs get old too. Okay. They get old too. So when you really want to make sure you have some healthy eggs, 30 37 is the most optimal time. But women older than that do very well with freezing the eggs.
Got you.
And so just, I guess, kind of getting into the financial piece of it. So if a person did decide to freeze an embryo, first, is that in essence, since it's a fertilized egg, is that in essence freezing a baby?
I guess it would depend on who you're talking to.
Well, that's the whole debate in America.
And, a lot of times that can lead to a lot of legal issues when the two people separate.
Right. That's where I was going.
Yeah, that can be an issue. So one of the things that's being done now is they are freezing oocytes and embryos at the same time.
Okay.
So let's say that the relationship doesn't last and the woman still wants to use her eggs.
Right.
It still has some oocytes there because they could just they're retrieving all at the same time anyway.
Right.
And then they are fertilizing the egg in the petri dish. So they just keep some that they don't fertilize and then others that they do.
Okay, got a little hybrid option.
Yeah, that's exactly where I was gonna go. Like, people be splitting up all the time. How they decide they're gonna keep this embryo?
I mean,
but that can be a major legal issue, right?
Yeah.
And if the couple breaks apart, here they have this embryo that's 50-50, right? It took both of them to make it, but what if they don't agree with what to do with the embryo?
Who get to keep the dog? I mean, it's not.
So those are things that really need to be discussed and put in writing on the front end.
Agreed. Put that in the prenup.
I'm not doing this with you.
Okay, sorry.
So you were talking about, the risk factors and studies in terms of, advanced maternal age. And so I know in our healthcare bias, we really got into fibroids because it affects a lot of women of color. And we kind of talked a little bit about my experience, PCOS, and I think it's becoming more common for women to also have PCOS. And so what are some of the, I guess, implications, with fertility for those who may be diagnosed with PCOS or some of the, I don't know if you want to call them risk factors with that situation? Like, how does that interplay with fertility? Okay.
So we'll do PCOS first because the risks are a little bit different.
Okay.
PCOS, the biggest risk factor is getting pregnant. Okay. Because some women with PCOS have difficulty with ovulating. Right. But once they're pregnant, they should be fine.
Okay.
It's getting pregnant with the PCOS. Now, with fibroids does not affect your ability to get pregnant. Okay. It may affect your ability to stay pregnant.
Okay.
Right? That's the difference between the two. Now, with fibroids, sometimes it depends on the location of the fibroids. If you have a fibroid in the lining of the uterus, then it can affect implantation. All right. Because, the egg gets released, the sperm goes up, try to fertilize the egg. It comes down the tube and into the uterus, implants, and then grows.
Right.
Well, it implants on a fibroid. There's not enough nourishment there, right? For that fertilized egg, and your risk for miscarriage is increased. Also, fibroids can increase your risk for preterm labor.
Okay.
Because of the location, things of that nature. Sometimes they increase your risk for C-section. Women can have degenerating fibroids during pregnancy, which can cause a lot of pain. So there's quite a few issues during pregnancy that you can have with fibroids. But the majority of women do quite well.
Okay.
So you said degenerating fibroids. What is that?
I apologize. It's a situation when the fibroid is breaking down and die.
Okay.
And so they can degenerate and die. They can regrow as well.
Right.
But they're going through that process of breaking down. It's an inflammatory process, and it can be very, very painful.
Okay. So then what I'm hearing is basically opposite times of the pregnancy. So PCOS is more like getting there or getting pregnant, and then I guess fibroids, more of the risk is staying pregnant, for lack of better words.
Yes.
Okay.
Yes, that's the best way to look at it.
Got you. Okay.
And so I don't, if you care to speak to it, but often I think women just the dynamics of change, we often decide to have children later because of stability, career, we often hear about that. And, I think a lot of I've heard the older generation, I'll say, that says you can't have both, right? You can't drive your career up and, have the kids. So you got to choose, right? But then when you choose, you there are risks to both, right? And so for me, I know I had my son when I was 32, so just shy of advanced maternal age, but still had to watch for the blood pressure issues and all of those things. So in your personal experience, did you have children or have a child at advanced maternal age? How did that affect you personally?
I did. So I conceived my daughter at 43.
Okay.
Had her at 43. Was very blessed that we only tried for 2 months. I did not require any assistance with that. And during my pregnancy, I did not experience any elevated blood pressures, diabetes, anything of that nature. I went into labor at home at 39 weeks, got to the hospital, 8 to 9 centimeters dilated. So everything was great, but then I ended up with a C-section because her heart rate, dropped, wasn't coming back up. And of course, me as an OBGYN, of course, I'm going to end up with a C-section, right? Yes. But for me, the benefit or the reason for waiting is that, I wanted to do everything in order for the most part. And I had this stability at 43 financially, right? And for me, it didn't matter if my relationship worked or not from a financial perspective.
Right.
I knew I could hold my own.
Right.
And, I got to a point in my career, too, where I was done making sacrifices for everyone else. I was ready to fulfill a lot of my dreams, right? And motherhood is definitely one of them. So there are pluses and minuses, in retrospect, because I love my daughter so much, enjoy her so much. Had I had her at an earlier age, I probably would have more. But at this age, I'm about one and done.
Done. Yes.
Right. But had I had her earlier, I definitely would entertain having more children. But just for me, I was at peace with my the financial stability made handling all the other stressors a lot easier. And that was just for me.
Yeah. And I think it's really, first of all, it's really good to point out that, like, she was 43, and it was like, it's pretty smooth pregnancy. It was just like, okay, I went in at 39 weeks, right on time, and even the labor, like, she's pretty much ready. So that's really, I think, refreshing to hear, because a lot of times you hear, especially if you're close to 35 or right at that line, you hear all the bad things, right? Like, oh, they have difficult pregnancies or blah, blah, blah. And so I just think that is really awesome to hear, and good for women to know that just because there's a chance, it could rain tomorrow.
Exactly. And women do well. The majority of women do very well. You just have to understand that the risks are higher, and we're going to watch you a little closer,
right?
When you get further along. Technically, women over the age of 35, your risk for stillbirth is slightly higher than the general population. Okay, women younger than the age of 35.
Right.
So they may do NSTs on you or put you on a monitor, I guess I should say, weekly or twice a week, depending on if you got other issues going on. Some docs elect to deliver you at 39 weeks. Some will wait till 40, So it's just important to know what the risks are, because I feel that all patients should have the opportunity to make informed decisions.
Right. Yeah.
Everything. And as a provider, my job is just to give you the information.
Right. And then, with the information, is it any difference, advanced maternal age or younger, that woman is carrying? Is there things that she should be looking for when she's advanced maternal age, like feeling a cramp or something that she would feel at 39 might be different than someone that feels it at 29, or just like paying attention to extra things, because I think a lot of that could be mental, and our, minds can play tricks on us too. But sometimes you just need to make sure you go in and get checked.
Very true. So, we already stated that you're at increased risk for high blood pressure, for eclampsia, for diabetes. So if I tell all women, if you're developing, especially women of color, right? Because your risk is already higher for those things.
Right.
And then you add advanced maternal age on top of it, you need to pay attention. So if you develop any headaches, any visual changes, chest pain, shortness of breath, feeling like, I'm just a little bit more winded than what I think I should be walking up these steps, please go in and be evaluated. Make sure that everything is okay. And the big thing with advanced maternal age is those kick counts. Okay, make sure that you're feeling the baby move. If you're not feeling the baby move, get something to eat, drink something really cold. And if you're still not feeling good movement, Do not wait. You do not have to call your doctor and ask for permission. You just going into the hospital or to the office to be seen.
It's good to know.
It is good information. I think a lot of the times when we talk about, having kids older, we always think about it from the parent perspective, right? But the reality is we are having kids. There's a child coming into an older parent. I think a lot of times we joke about the graduation. Oh, you're going to have the 65-year-old parent that's at the graduation. But, there are some downsides to having children older, to the child itself. And I think one of the biggest ones that I think about is, like, when we think about ourselves at 40, 45, 50, and if those that are blessed still have their moms, I still need my mother, right? But for a child that's coming in and they're 50, they might, in 20 years, when they're 20 years old and 18, just getting ready to join into the world, they might have a 65, 70-year-old parent. So, if they're blessed, and with our, I guess, lack of ability to really hone in onto our health, and not taking care of ourselves as good as we should be, there's a really high chance that the older parent might not be around,
or you lose your parent at a young age.
And I think, so how do you feel when it comes to that? Like, do you feel like that's, because I've heard like that's selfish. Like, why would you want to do that?
That's okay.
Yeah. Well, selfish. It depends on how long you plan on living, right?
Right.
So, first of all, there are studies that have shown that children born to mothers who are 35 and older actually do better developmentally during those first 5 years. Because older moms have more patience, they have more.
That's true. I can see that.
Increase the handle emotions, things of that nature. So children do better, the studies during those first 5 years. Now, what I think you hit on is very real. It's something that I think about all the time. And as a mother who was advanced maternal age, I feel like it's our responsibility to really try to be as healthy as possible, right? For the sake of our children. And from a financial perspective, we really have to be aggressive with putting things in place to ensure financial stability for them if it happens to us. It's so different than when you're having a child at 20. Right? You have to be more aggressive on the front end.
Right. And I think, to the second point, I mean, shameless plug, please go back and listen to the insurance and the estate planning episodes, because those are the keys, right, for what you're saying when you say be aggressive about planning for that child. Those are the things that are going to build, I think it's a sexy term now, that generational wealth, but those are the keys to doing that. Life insurance and having everything in place so that if and when something happens, that child and your family the only thing they have to worry about is grieving, not how are we going to pay for this, how are we going to do that,
especially if they're going to be younger. I think it's one thing to there's always risk. We know that there's always risk. A 20-year-old 25-year-old parent could have a child
could pass away
we know that. But the reality is, when you have a child older, there's more of an expectation and a likelihood that that's going to happen, right? So financially, I just think if that's your choice to make, to have children older, at least take those, like you said, take those proactive steps and aggressive steps to make sure that they will be okay. Like to make sure that like you said, that the least thing that they would have to worry about is the emotional grieving.
Right.
And you also have to take those aggressive steps in making sure that you foster a village.
Right. Absolutely.
You know what I mean? Where they're emotionally not solely dependent on you.
Right.
It's very important to have at any age, right? Or a mother for any age, because we don't know what the future holds.
Right.
It's important to create that village where your child has more than one person to go to for support.
Oh, yeah.
Right.
I think that's so important. That's a really good point. Yeah.
But to challenge the statement of selfish, like, and not to get, because, I can get petty. But I think at the end of the day, there's a take. It's give and take, right? So to me, if you're having a child and you're older, and for these reasons that we've discussed, whether it's financial stability, whether it's some people are traditional, they want to be married, they want a 2-parent home, what have you, I think there are benefits and cons to both. So if you're going to say, oh, it's selfish, then why isn't it selfish if you have a kid and you're not financially prepared? So I just think, I don't like it.
I agree with you, Lee. Totally. Others cannot put their expectations on other women. You don't know what's in her heart.
Right.
You don't know her story.
Right.
Most importantly, you don't know her story. So, we just need to try to support all women, regardless of their situation.
Yeah, totally agree.
And the other thing, we're talking about fertility, right? So we don't know if that woman has wanted children or been having issues conceiving or issues carrying. Yeah. So I think,
because there is a strong presumption that if a woman has a child older, that she could have had it younger. Absolutely.
Right.
Yeah.
1000%. No one ever thinks about the fact that she could have been going through that journey for 10 years.
Yep.
Absolutely.
Yeah. So important. So, are we going to shift to awareness?
Yes, let's shift to awareness month.
So, it is gynecological, I have to break that down. Awareness, right. You move that mouth. And so, we wanted to address some of the issues surrounding, like cervical and ovarian cancer, right? And so I guess to start, maybe what are the screenings, if they exist, for both types of cancer?
Well, most people know about cervical cancer screening, which is the Pap smear, as well as HPV testing.
Okay.
And so, it's always changing as far as what the guidelines are.
Right.
But it's very important to stay on top of the testing. And it's important too, I just can't say this enough. Even if your Pap smear, your HPV was normal last year, you need a pelvic exam every single year. Okay? Every year you should get a pelvic exam. There technically is not a screening test for ovarian cancer. Okay? You know how we catch ovarian, or how we want to catch it, is by doing a pelvic exam on you. And if that ovary feels enlarged, we get an ultrasound to see what's going on. We don't want to wait until you come in with your belly extended, until you come in with severe pain, or you just can't eat anymore. Then you're likely at advanced disease. That's why ovarian cancer is called the silent killer, because early in the game, you really don't have symptoms. Right? So just because that Pap smear is normal does not mean, and you can wait 3 or 5 years. You still need to see someone every year, especially if you're sexually active. And I can't say it enough for my elderly ladies.
Okay.
Still get that exam every single year.
Now, is there, I know you're not an oncologist because you mentioned like the elderly ladies. Is there like a thought that maybe those cancers aren't, like they're no longer at risk, or is there a reason you're seeing like the
thing is that, once you're over the age of 65 and you've had, 3 consecutive negative Pap smears, no recent history of, bad Pap smears, and all these tests have been done in, the past 10 years, you don't have to get Pap smears anymore. But too many people equate Pap smear to pelvic exam.
Yes,
it's more to a pelvic exam than a Pap smear. You know what I mean? Elderly women get vaginal cancer. Do you want to wait until it's gone from the inside to the outside, or do you want to wait until you're bleeding and then like, why am I bleeding? I'm postmenopausal before it's diagnosed.
Right.
So if you're getting that exam every year, we would know. Also, it's a time for you to have those sometimes not quite comfortable conversations with your provider. are you irritated down there? Maybe you don't have cancer, but you need a moisturizer to help with the irritation. We want to treat it early before it gets bad.
Right.
Because even when it comes to the intimate area, it's all about preventative medicine.
Okay.
And so to back up, because I honestly will say, when you said a pelvic exam, that's all I thought was pap smear.
Yeah.
Well, most women do.
Yeah. So can you elaborate on that a little bit?
So, when you go in for your annual exam, you're like, it's time for me to get that pap smear. They usually are listening to your heart, lungs, all that, did your breast exam, felt your belly. And then when they go down to the pelvic exam, they look on the outside, they slide the speculum in, they use a little brush to get a collection. Once they take that speculum out, they're doing an exam with their hands. Okay. So when we do all that, we're looking for a multitude of things, right? So we're looking on the outside to make sure that the vulva, that's your external genitalia, looks normal, that we don't see any bumps or lesions, okay? That could be maybe a non-cancerous type of disease, or maybe even cancer, okay? Because women can get vulvar cancers as well. When we put that speculum in, of course, we're collecting a pap smear. We're using that brush to swab your cervix, but we're looking at the vagina, making sure we don't see any lesions, making sure it's not super dry, and maybe we need to give you some type of moisturizer, things of that nature. When we do that exam with our hands, we're feeling your uterus, making sure it doesn't feel enlarged. And we're feeling your, what we call adnexa. That's your tubes and ovaries, okay? Making sure that they feel normal as well.
All that pressure you feeling. That's
I was like, y'all can feel a lot from
all that pushing.
Yeah, we're pushing for a reason. We're pushing for a reason.
It's a lot happening.
Now you know. So if you do, fortunately, get one of the cancers that you mentioned, because there were a lot that you just mentioned: vaginal, vulvar, cervical,
ovarian.
That's a lot of cancers that can go on down there. Yeah. I know early detection is the key, obviously, to any cancer. But what are the success rates for treatment? How is it treated? Is it treated the same way that breast cancer will be with the radiology and chemo, or how is it treated?
It depends on the cancer.
Okay.
And it depends on the stage. Okay. So like early cervical cancer, sometimes depending on, if the woman has children or not, all those things, if we catch it like carcinoma in situ, sometimes they can just have what we call a cone biopsy, where you're just cutting a cone out of the cervix. Sometimes a simple hysterectomy fixes the problem. Even for early stage uterine cancer or endometrial cancer, hysterectomy may be enough. This really depends on the stage. Sometimes with a vulvar or vaginal cancer, if it's caught early, women may only need what we call a wide local excision. All right, so we cut it out, but we make sure we cut a portion large enough around it that there's not microscopic spread. Right? Now, women who are in later stages may need a lot more. They may even need radiation to the pelvic area, and that's not fun at all. Sometimes they need extensive surgery, which can require removal, not just of the female organs. The bladder can be involved, the bowel can be involved. It could be very, very extensive.
Right.
Yeah, so they may have chemo, radiation. It all depends on the type of cancer and the stage.
Got you.
And is there, if once they do the procedure, regardless of the stage, is there a likelihood of recurrence at the way it is with breast cancer?
It depends on the type of cancer and the stage, what the risk of recurrence is. And for each type of cancer, it can be very, very different.
Okay.
Yeah.
And so, if because again, I know you're, on the other side of things, though you might be the first point of like, may need to go get that checked.
Right.
If you're aware, like, what are maybe like the success rates if you're, detected early, for some of those types of cancer?
Well, like for example, for cervical, it's very, very high.
Okay.
You know, so what we look at is like what we call like 5-year survival rates.
Mm-hmm.
And so for some, when you catch them super early, you're talking about 95%, right? Mm-hmm. If it's a stage 1 endometrial cancer, right? So it's just in that lining and we do a hysterectomy, those women tend not to have problems anymore.
Right.
It's all about catching early disease.
Right. Got you. And so one of the things, like, it always just really rubbed me wrong. And so I just was like, okay, let me just get someone to explain this. I was told at the doctor, I guess, I don't know if it's an insurance thing or what, but if you've had a normal pap smear, they used to do it just every year. And now they're saying like, oh, you're fine for 3 years or what have you. And again, please correct me because this is what I was told and I just want to make sure we're not getting false information. So it was explained to me because I guess cervical cancer is slow growing, that they don't feel that you're at risk or as much risk with normal paps to wait 3 years. So what is the thought behind now making it so that we're waiting 3 years between these?
Okay. Well, just so you know, the guidelines have even changed for some women where it's now 5 years you can wait. Okay. So you're right. We used to do pap smears as soon as you became sexually active or 18, whichever came first. Right. And as we did more and more paps, women, they come back abnormal. Women were ended up with the LEAP procedures and, you know, different things, cryo to treat the problems for mild disease. All right. So let me explain that real quick. So when we do a pap smear, if it's abnormal, sometimes women just have what we call cervical dysplasia. Okay. Or they may say to you precancerous cells. With those, it could be mild, moderate, or severe. You may hear the words low grade, moderate grade, high grade. The gist is the higher the grade, the more likely that can turn into a cancer down the road. Okay. So you had all these women coming back with, you know, mild or moderate dysplasia. We're leaping them. We're doing this. We're doing that. Subsequently, they're having problems with cervical incompetence when they're pregnant. You know what I mean? All these different things. And once we had all this data and we're able to look at it, we realized that we're doing a lot of procedures on young girls. And the likelihood for this mild dysplasia to turn into a cervical cancer within the next few years is extremely low. Right? We even know that 60% of mild dysplasia has a chance of going away on its own without us doing anything at all. Right? The other thing that we learned is all of this is tied back to HPV or the human papilloma virus. Right? And in order to develop dysplasia or even cervical cancer, you got to have high-risk HPV in your system. Now, I'll just leave it at that because that's a whole nother discussion. We want to talk about HPV. But when we do co-testing, we know that pap smear is normal and your high-risk HPV is normal. We feel very comfortable that within the next 3 years, you're not going to have a cancer. So that has been why it's been pushed out. And now it's being pushed out even further. Now, some women have concerns about, you know, doing a pap smear every 5 years. Even if you're getting that exam every year, don't forget that, okay? I personally feel, and it's just my opinion, that for women of color, there needs to be more studies done on us because of the aggressiveness in cancers in us. And if a woman of color sees me and wants to have her pap smear done prior to 5 years, I have no problem doing it. And I haven't seen any insurance companies not paying for it. Right. So
that's exactly what I was going to ask you. Is it really an insurance issue?
I mean,
but that's good that they have it.
Not that I've seen. So it's really not an insurance issue. Check ahead to confirm that they'll pay for it. Thus far, from what I've seen, they have.
And that's good. And I'm like, even if they don't, if that makes you feel more comfortable, then consider.
Ask up. Speak
up.
You know. Yeah, for sure.
the majority of providers are going to be perfectly okay with going ahead and doing it.
Mm-hmm. Mm-hmm. So are there any, aside from food, goodness, and the things that's in our food, are there any contributing factors to the types of cancers that you name? I know you mentioned HPV, which, if I speak out of turn, it is a STD, right?
Well, I told you we could do a whole talk on HPV.
There we go.
Can you acquire HPV from having sex? Yes. Okay. But we don't know all the details around HPV. Okay. If you walked into Walmart right now, 80% of women in Walmart right now will have HPV in their system sometime in their life. So is that really fair to call an STD?
Now, is that different from Target? Are we...
Not Walmart versus Target.
I'm just saying.
They in Target too.
Okay, let's move along.
In Target.
Okay.
So,
interesting.
And there are nuns out there with both cervical cancer and high-risk HPV. So we don't know all the details about it. Mm-hmm. We do know that you can acquire it from having sex.
Mm-hmm. Okay.
But because we don't know all the details, I don't like to call it STD.
Fair enough.
Because it makes women feel uncomfortable.
Right.
It makes them feel dirty and fair.
Got you.
And that's all the more reason why we need to really have our young girls and boys vaccinated.
Mm-hmm. Yeah, they have the. I used to see the commercials for the HPV. It was like a shot or something.
So boys can get it too. Confirmation.
Those are the little vectors running around.
A vector. Well,
okay.
Hey.
So
yeah.
Team boys
running around.
Are there other additional contributing factors? Like I said, I know you mentioned HPV with the ovarian. Are there other contributing factors, other STDs maybe, that contribute to?
So cervical cancer is associated with high risk HPV, not low risk HPV.
Okay.
Okay. So not really with other STDs. Okay. Now, having STDs means that you had unprotected sex and therefore more exposure likely to high risk HPV.
Gotcha.
Right. Mm-hmm. Now, if you are immunocompromised, for example, someone with HIV, then you are more likely to have aggressive disease if you develop dysplasia, things of that nature.
Mm-hmm. Got you.
Yeah.
Okay.
And when you mentioned ovarian cancer, you said it was like a silent killer, because early symptoms are not there. They're just right. Are there symptoms of cancer or things that a person can look for? Signs, because of course in the breast they tell you the lump, you go get your checks, you can do your self checks at home. I don't necessarily know if there are sex checks for the other cancers. Are there things a woman can look for?
Well, every woman should be looking at her private face.
You should
at a absolute bare minimum once a month. Okay. Because there you can develop bumps down there that are not tender but can be abnormal. Okay. You need to know what you look like and be very comfortable with you. And the more comfortable you are with your private face, the more comfortable you will be talking to your provider, seeking help if you need help, asking questions if you're just not sure.
Right.
Right. So that women should definitely be doing that. Women should, if they notice a discharge that's abnormal, because some cancers present with a discharge. Okay, they should have that discharge evaluated. Even if it's a watery discharge, especially in our older women, if they are noticing a watery discharge and they're like, okay, this is not normal for me, that's one of the signs sometimes of cancer of your tubes, of the fallopian. Okay, so they want to make sure that they go in to be evaluated if they're having those symptoms. Of course, any woman with postmenopausal bleeding, even if it's just spotty, cancer must be ruled out. Okay, because almost all of them, you can have postmenopausal bleeding. So very important to do. Women who are not postmenopausal, if you have abnormal bleeding, get it checked out and just make sure that everything is okay. Women can sometimes have an endometrial cancer. They're not postmenopausal, but that bleeding is abnormal. They just don't stop bleeding. So your provider may do an ultrasound, may do an endometrial biopsy, things of that nature.
Yeah. And I think it's so important because I have had conversations with people. I think women, especially depending on how you're socialized, right? Depending on what family you come from, it's just so taboo to talk about your vulva and vagina. And so I think, I've even had conversations like, so you don't look at it? You never just take a little mirror and know?
Some of them have never seen it.
And so Dr. Sin said it very professionally. But I just can't say that all WAP ain't normal. So just know you need to know. You need to know what it looks like, what it usually smells like.
Right. So you can see
what's your discharge usually. So it's really important to get to know yourself.
Yeah. If you're losing weight unexpectedly, that's a concern. You always want to make sure that's evaluated. If you lose your appetite, and you just early cessation, you can't eat much, super tired all the time, you always want to make sure that you're going in to be seen.
Yep. So important.
Yes, it is. Well, we have appreciated, as always, you giving us this wealth of free information. Okay. There was no foul photo that needed to be pulled.
They're not going to send no bill to your insurance.
Okay. This wealth of information. We appreciate you, Dr. Wesley. So let's talk about you. Where can they find you?
Well, I am on all forms of social media at Dr. Cyn OBGYN. That's DRCYN OBGYN. I have some big things happening within the couple of months. My book will be dropping within a month from now. And I have a product line for intimate wellness and beauty for dark skin. It's called Beauty Below. And if women want to sign up to be the first to know about launches and all that good stuff, discounts, everything else, you can go to Beauty Below MD and put in your name and your email, and you'll be notified about everything.
I'm so excited about that. So it is so needed, especially like when you go into the stores. Those products do not look like they are for us by us. So it is so needed. So needed.
Yes, because we have a different set of issues that we deal with. All women struggle with the negative connotations that are tied to the vulva and the vagina, right? That's all women across the globe. And we're struggling with this for years. And we're finally starting to get to a point where we're starting to talk about it, right? And women are starting to get comfortable with pampering their private face.
Right.
Women of color have additional issues. With the coarseness of your hair, you're more prone for ingrown hairs in that area. Women of color are more prone for hidradenitis suppurativa. We could talk about that at another time.
Please.
Hyperpigmentation, where you do get a bump, then it's dark for like the next 6-9 months down there.
7 years.
Right. And then we had this whole issue of the historical wrongs, right? That have been done to our ancestors and the role that has played on our self-confidence as Black women, on our freedom to be fully comfortable with our female sexuality. Right. And my goal is for every woman of color to have what I like to call Black vagina confidence. Right. And so it's going to be a movement.
Yeah, it is.
I want every woman not just to enjoy the products and to beautify themselves. I want them to be well. I want them to be knowledgeable. And when you know your body, then you have true stewardship over your body.
Amen. And so we were going to have all of that information in our episode notes for all your BVC needs.
Okay.
Not the BVC needs.
You know. So thank you again for being here. We tend to have folks back as the topics come up, so we are sure we will have to see you again. Quick, do you have anything?
I don't. I'm just super, super excited about your product line. I know that I think a lot of women don't even think about the things that they use, especially with like body washes, and how that can affect your scent, right? And how it really can change. How do you say it, scent? It change. What does it change?
Your flora?
Yeah, it changes your flora and your scent. But just I was gonna say DNA, but it's not the DNA. I know that's not the right words for it. But it literally has a chemical imbalance, right? It does impact
your
that.
pH.
So, yeah.
And your microflora. And in my book, and that's called Beauty Below as well.
Yes, I like
it. Be consistent.
Like I said, a guide to intimate wellness and beauty for dark skin. I do a whole segment on Black women and bacterial vaginas. Because Black women are like 3 times more likely to have it. And so how does that make you feel?
Right.
It makes you feel like, you're not as clean, or you're doing something wrong, or what's wrong with my body. And that's not really the case.
Right.
So I dive deep into that in the book and help women really understand how to keep it away.
Yeah.
Right.
So I appreciate you guys having me on and allowing me to share my passion.
Yeah.
Yes.
We're super excited. Like Lee said, we will definitely have that information. This is not a book or a product that you don't want to.
Right. And especially for the young girls, because I'm going to just say, I used to tear mine up with that Bath and Body Works. I'm just going to be honest. You felt like it should smell like cherries. So,
definitely have that product, on our YouTube. We'll have it linked below. We'll have it on our podcast. When you go to our website, we'll have all the information, so you could just click, link, and go and sign up for her pre-sale. So thank you, Dr. Wesley, for coming back on and sharing all this information again with the D&D family. And we look forward to speaking with you again.
All right.
I love speaking with you guys. Thanks so much.
Thank you. Bye.
Bye.
All right, D&D fam, you can continue to follow us, Facebook and Instagram. We're Divas and Ducats, www.divasandducats.com. Subscribe to YouTube. You're watching. I don't know why you haven't subscribed by now. And so we will be back in a couple weeks. And in the meantime, in between time,
have a great attitude.
Hey, bye.
Bye.